Greetings, I'm Dr. Kennedy, and I'm going to talk a little bit today about the features of the NeuroFlex. We're very proud about the years of development and ideas that came together to create the features of the table, and all of them have a great practicality towards patient outcomes and towards clinical efficiency. Firstly, we built the headpiece. We used to call it the hammerhead shark position or shape, so that the patient could assume in the prone posture an elbows down comfort position for their shoulders. Instead of having their arms up, holding on over their shoulders, causing strain on there, they didn't need to have that position. They could, like an adjusting table, lay with their arms at 90 degrees. These elbow supports, forearm supports can go to any height for any patient's arm length. Also, we have two hand grips in front that allow the patient to grab hold and to add as much tension as they might need by their hand grip to keep themselves from slipping. We're big proponents of the concepts of the directional preference, the McKenzie. And the McKenzie premise is that if you can find a movement pattern that improves or diminishes pain, use it. In the prone position, many patients find extension of their torso to be very valuable. In order to sort of improve on the benefits of putting somebody into an extended position, we built our torso portion of the table with the split at the waistline. Almost all tables are split at the mid-torso or at the sternal region, which doesn't afford you the ability of getting that extension and to get the vertebra into that extended position. So we can do our decompression simultaneous with the body being pre-positioned into an extended posture. And this will help, we believe, to promulgate reduction of disc herniations much faster than other methods. We put a drop piece, a very crisp 7-inch drop on the middle section here so that doctors could utilize pre or post, not during, pre or post pelvic adjustments. Obviously, the pelvis is implicated in at least 12 to 15% of chronic back conditions. Not addressing it can be a problem, so we have the drop. We have a bolsterless leg elevation section, and this was a very important advent to our table and in our designs, we believe. It eliminates the use of these heavy bolsters that go underneath the knees, forcing the patients oftentimes to lift their entire pelvis or legs while they're in pain, causing some more pain. By increasing the angulation, we can get more of a tilt or more of a Fowler position for the body's position on the table. It also flexes the pelvic girdle, creating a pelvic tilt, reducing the stress on the lumbar spine and flattening the lordosis simultaneous with supporting the legs. The front piece, the most caudal piece, is on a slide, friction-free sliding section, like most traction tables. We want to reduce the x-axis, that is the horizontal plane pressure or frictional resistance of the body. So we put these friction-free rollers. Our table utilizes a variable resistance spring, which affords us anywhere from about a 40-pound resistance to 0. At full reduction of the spring, you can open the spring with just finger pressure. It opens 3 to 4 inches before it encounters the spring resistance, so it still controls the unwieldy motion of the table and allows the patient's lower body to participate most efficiently with the back and forth motion. We don't necessarily have to increase force on the motor. We can decrease the tension of the back spring, and the patient can feel more movement of the table and therefore perceive a greater sense of pull. We have a hook on the table, and this hook allows the belt that we have designed specifically for the table so that the lower strap can be held down when we utilize the important portion of the table we call the NeuroFlex. And the NeuroFlex allows this section here to go down to a position that will reduce pressure at the neuroforamen. So a patient comes in with a clogged neuroforamen from a disc herniation. but they're a younger population patient. They have a movable or a hydrated disc. We want to treat them in the preferred prone position. This affords us the ability to pre-position the body into flexion, reducing the tension on that nerve root or that foraminal area, and allow us to develop a pull which is going to be axial. We are not pulling the body in flexion, we're pulling it axially, but we're pre-positioning the body in flexion. This is a very important difference between our table and other tables. This hook here affords the belt to be held down so that when the pull takes place, the pull is very axial, the body being pre-positioned into flexion. Finally, we have this section here has a face hole. And this face hole affords us the ability to put a patient in the alternate position. Their head will be at this section. And we can develop the patient and put the patient into an inverted posture. So the inversion is about 30 to 40 degrees. But what it allows us to do, studies have shown that in inversion, people that have hypertense lumbar spine or mid-back muscles, when they go to about 30 degrees of inversion, their muscles go completely electrically silent, which is a problem for many people who have chronic back problems. Their muscles remain active even after they've laid down for several minutes. This affords us the ability to manipulate, massage, utilize instrument adjusting while the patient is comfortably prone, with a face piece and an arm cut out in this direction. Finally, we also have a vibration motor which vibrates at approximately 50 hertz. This vibration motor affords a goodly portion of people, especially the elderly or the chronic back pain patients who have this hypertense activity in their lower backs, the ability to relax quicker than they might otherwise relax. There have been some studies on EMGs of prone and supine positioning. In the prone position, muscles have a tendency to go quiet sooner. Supine takes a little bit longer. The vibration can facilitate that reduction in muscle tension.